Thank you. I've never had a panel that was so self-regulating and so excellent. Because, as you know, one of the best things.
Death threats we got.
One of the best things, the reason for that is you guys are good. So the goal now, and this is to me the most exciting part of the conference and the session, is to allow interaction. We have a great panel up here, a lot of knowledgeable people here. What I have learned, I don't know, do we have mics or people just have to speak loudly? So I'll repeat the question because this is going on for posterity. And we want that. So I encourage you, excellent group of people, excellent group of organizations, excellent projects, but they're all early on. And as I alluded to, I hope that in 10 years we'll be at a place that we've come on the medical side. And so part of the activity here is to begin to forge that path. So I encourage you to press them a little bit on their specific projects or to raise points that you didn't hear. I would ask, although I complimented all of you, one of the negatives for all of us, me included, is we sometimes like to hear ourselves speak. So I'd encourage you to limit yourself to probably a question or a very, very quick statement and question. But and then I'd also suggest that we target it to one person if you have a person in mind, or you can volunteer, and we'll try to keep it lightning round. So why don't we get started? Who'd like to get us started with moving the discussion forward? And don't be shy. The first one's always tough. Thank you. So stand up, name, rank, and serial number, and then your question, please.
Joe Schneider, retired informaticist from Dallas, Texas.
Thank you.
And also, my question is for the panel. We have heard a lot, you've done a very good work, but we've heard a lot about gathering data from all sorts of sources. I didn't hear anything about gathering information from individual patients. My mother has all sorts of problems in that regard. PHI has all sorts of problems. How do I go about accessing this? Are there thoughts about accessing this, enabling you to get it directly? Actually, just likely to encourage plastic water bottles, eventually getting them. This is something.
Thanks for that. Thanks for that. Probably about 5 points, but I think good ones, all of them. I think the main point is how we get consumers, either the patient or caregivers, involved in the social determinant aspect of correcting their data. Ross, you want to take that?
Yeah, it sounds like a question for the HIE at the table. And this is really tough. I will just say that at the outset of CRISP, the original data model, or the original design of CRISP, imagination of CRISP, was much more like a medical record bank that was controlled by a patient caregiver, and that HIE of one. And the practicalities of doing that just moved us on a different path pretty early on to connect early on with the ADT messages first, and then other clinical documents. And we're starting to swing back around. The challenge we have as an opt-out state, we're more of a B2B player, a business-to-business player, than a B2C player, consumer player. And so our identity management for individuals is much more based on probabilistic matching for our patient identifiers, and not on individual enrollment because we're opt-out. And to retrofit that in is very challenging for us, but it's definitely the next piece of this. And I emphasize, I've got songs out there say, give me my damn data and stuff. But I'm all about that, but it's really hard to do that in the HIE infrastructure that we have.
Thank you. Do you have a question? Please.
Love all the stuff you guys do. But I think what I'm worried about when I hear about CRISP is that there's something to go outside of the to get that. I won't do it.
Do you want to bring it down to a social determinant aspect of that? Because that's true for anything.
Well, we have everywhere.
Okay.
In our so many different aspects in that one. Trying to figure out how do we all
Okay, again, given that the strength of our healthcare system, informatics today, is in fact the Dukes of the world and their EMR systems, how do we take that and bring it to the focus of what you would like to do in the future? Margot would like to take that.
Great question. There is an effort underway to convene some of the people who are asking those kinds of questions. But we're going to be looking at what codes exist for coding social determinants out there that go into the PHI right now. And then there will be some discussion about what we want to do in the future to perhaps make that a thing that another organization is part of, so that we can identify missing codes and figure out how to move forward so that providers become really a multi-faceted activity. Do you want to say something?
No, we're going to keep it moving quickly. So, but anything else? Now, I want these people to feel, two people here, but I want these people way over there to feel part of it. Back in the corner, please. So thank you. I think the main point is that we're not here about the data or the data geeks. We're here about the community and making them healthy. Is there evidence to date from your projects, most of which are early stage, or does anyone have a comment? Would you like to, Mary Ann or Jason? I'm trying to move it down.
Really briefly,
yes.
Just we don't have any data to substantiate the outcomes that were affected by the level of data sharing occurring today. I think that that's a rich area of study. So right now I would say in the rollout stages of trying to demonstrate that this connectivity is being used, recognizing that there are issues with the value of the data being transmitted today.
So I'll just add, and I think you can add way more than I can.
Well, I'll let you add, but we're going to move on
super brief.
real quick.
I think the other piece that we didn't talk about was initiatives from CMS, the accountable care communities or accountable health communities, where this is very much a part of that work. But I think the stuff that you spoke to is more.
Thanks for that question. And of course, that is for the empiricists in the room and the evaluators, that's the $64 billion question. Let's, in the corner, you've been patient.
I'm 6 years old. I'm a student at the University of Maryland and also active in the Odyssey, which is spelled OHDSI, open source collaborative and common data model. And I've also recently been associated with two efforts to tie environmental data to health data. So we have the health data in a common data model, and one's an NSF grant, one's part of Odyssey, are trying to figure out how to make extend the common data model or make a common data model so that we can start tying the geographic data, which is social determinants of health and environment and all that, to the patient data. And I'm just wondering, and this is for analytics, not for, so it's for data warehouses. So it's simple. But I'm wondering, are people looking at common data models? And also, if everybody's starting to link this without talking to each other about common data models, are we going to have a disaster that could be a
Thank you for reminding us about the common data models. It's only taken us, what, 50 years to get a sort of common data model, sort of successful in the medical, and this is cute. So I don't know if somebody would like to, and I heard you say simple, but
well, Ross and I both at the same time said yes and yes.
Okay, so is that the response? Would you like to say more? Or?
Just to say that people are thinking about that and know it's going to be on the model. Not everybody can have that conversation, so it's a team sport. There are a lot of convenings going on to try to share information.
And we're going to have to get out our comfort zone because colleagues in all these different areas, in housing and social services and the environment, have done some of this, if not quite in our mindset. So thank you. Yes, question here.
More to respond to the point that was earlier about where's the empirical evidence. The best repository right now for data on social interventions is the Siren Network, which is run by Laura Godley with UCSF. If you Google Siren UCSF, you'll get there. And Siren is the Social Interventions Research and Evaluation Network, and they've created, I think, the best repositories there is out there on all the research that's been done on social interventions out of clinical settings, meaning social interventions. They've also got a great repository of social performance screening questions. I recommend everybody go to the Siren website. It's where you'll find what empirical evidence. There it is. There's a lot of data. Anyway, I'm Rachel Gold from Kaiser.
Yes, thank you for that public service announcement, not a plug. But to remember that, and I've seen that site and it is phenomenal, but it's social determinants in general and not just interoperable data. So we need to, although there are probably a few that do that, and there's usually N of 400, and 3% meet the PRISM RCT standard, so we have a long way to go. However, I meant what I said about being the best that there is, so thank you. Other, over here, please. Again, several very good comments there, but I think that the main one is that e-referrals for social services is different than an ophthalmologic consult. Comments on privacy, and also as someone that started for the first time to link in social services data, including police and other records, there's actually far less HIPAA requirements for all that stuff than we're used to dealing with. But I don't know who would like to answer that and is knowledgeable about the HIPAA-like issues.
Well, we actually have been in conversations with United Way 211 programs about this very issue, and that's just one example of many where they're in a clinical encounter. Basically, a clinician wants to refer the individual to social services, and so their organization's United Way 211 program. So we believe that there's a current foundation of privacy and security that's already accommodated in these data sharing networks and legal agreements. There are different relationships, however, that could be invoked around a business associate relationship. So I would say there's not a firm answer right now, but we need to do more analysis around it, and it really helps to have a specific example that we're actually trying to put into practice as pilot, for instance.
So thank you. I do think that the whole legal, and aside from the standards, I mean, think about all the stuff that they know about us that have absolutely no confidentiality standards, and 70% of that is what we're bringing in. But I do think that we're going to probably have higher ethical standards than Google and Facebook will. Okay, we have about 5 more minutes. Let's keep it going. Right over there. Yes.
Actually, build upon this question, that I was going to have so much of either APM or access to I work in ACO, so we are trying to build some of these programs, and one of the questions that keep coming up from our what does this do to our medical liability? Because now you have access to the data that you prescribe, and some indication doesn't have the funds to buy those medicines. Am I responsible?
Good question. Again, the liability as we get more into the social, I don't know who wants to deal with that one. Ross? No? Or not? Anyone else? I don't even put it in.
I've had an answer for every question.
I also realize you're the only MD on the panel, so you're used to liability, yeah.
This is a question that we've heard from the beginning of time with the whole concept of bringing data in from outside sources. That's one of the first defensive responses from clinicians saying, what about the liability of being exposed to this information and if I don't act on it properly? I don't think it's a new question. I think what we're seeing more and more is, I hope that the tip is going to be you know, what is your liability for refusing to look at the stuff that you could have access to? And is that really responsible practice? I think that's a much more important question. But that's a personal opinion, not a legal opinion.
Margot, some quick response to that?
Thank you. Also not a legal opinion, but from one of our sister endeavors in telehealth. We've done some work looking at with the Physician Insurance Association of America, Physician Insurance Association of America, PIAA, looking at malpractice concerns about physicians providing remote treatment. And similarly, there are no malpractice claims that haven't been kind of small ones that have been settled. And basically the expectation is, why didn't you provide remote services? Rather than, I'm concerned about, I didn't develop a relationship.
Again, it's on the list. Right here.
Paul DeMuro, I'm a health informatics attorney in private practice.
Okay.
I don't necessarily want to answer the question.
Okay, you have a question to ask, right?
For like the person from Kaiser, does anybody do any work in the prioritization of these, addressing these social determinations? So I know Kaiser is the leader of that. So we can't do everything. I can't sell clients on building trees, okay? I can sell them on bringing trucks with fresh fruit and vegetables. Does anybody do any work on priority?
I mean, just that's a great question. I think we are, as a full-time academic with dozens of fellows and graduate students, trying to answer what do we know and what we don't know. It's complicated, and I do think the Siren Project and others, we do need to do that collectively, and we're a way off. And yes, Kaiser and the VA and others are trying to do that because they have populations. And in Maryland, as you alluded to, we now have an all-payer system that CMS says they're going to be paid for how healthy the community is. I have never seen the tertiary care facilities care about it more. So it does come down to the money and the evidence as part of it, and the evidence isn't great. Anyone disagree or add to that?
Just to say that I think that most people agree that, and Bill said this, it's about housing first. It's really about housing first.
The evidence is pretty good for housing, although food's pretty important
Food
too.
is important
Right.
too.
Maslow plus. Okay, we have time for 2 or 3 more questions. Actually, 1 or 2 more questions. Over here, I've been ignoring you here. Any other questions? Help me. Raise your hand. Oh, okay, there we go. Please.
So I hope I'm not the only one. Cupid Gas can political transformation of a regional health plan in New York. I hope I'm not the only one hearing the parallels of the early days of CPOE and the EHR adoption and interoperability as this inflection point for social determinants of health. So my question is, to the panel, what do you think is the role of government in kicking us out of sitting on the fence? And secondly, what's the role of vendors? And I'm not talking about EMR vendors. There are vendors in the social determinants of health space, which I particularly did not hear reaching out across the
So as we finish up, this will probably be the last question, and it's a good last question. Let's hear from our friend from the government who's here to help, Jason. and we love the CDC. And who's the most corporate on the panel? I don't know. Perhaps you've been in a corporate setting? So why don't you two have the last words?
Yeah.
Sorry.
That's a great question, and it would be wonderful to see the federal government step more strongly into this space with appropriate policy levers to help push this.
And I think just from the lessons learned with the eHealth Exchange, that the government has been very successful in supporting incubating early instantiations of these types of projects, that certainly with the NHIN, now eHealth Exchange, be a great opportunity to bring the community together to develop some foundational evidence.
Thank you. And there's nothing we do in this country that works well that doesn't involve both government and corporations. So thank you for raising that point. And also join me in thanking the group for a very great session. And I think we're right on time, and I'll turn it over to Brian. Thank you.